So, why are we even talking about plan B over here? This is what exactly happened on the Crown study which was presented. Lorlatinib has a 60% PFS rate at 5 years. We also won the World Cup over here. So, why this plan B when you have a very good plan A? The subsequent reaction to this actually is that even if you have a plan A or plan B or whatever, this will fail. No drug is going to cure you out of your disease in a stage 4 non-small cell lung cancer. And that is why you need a plan B. And that is why you need someone to know what exactly happens after this. So this is the success stories which everybody comes and shows us. A 5-year PFS, a 34.8 months PFS with alectinib, a 60% PFS rate at 5 years with lorlatinib. But that also means that after 34.8 months or after 40% of people will need a plan B. And that is why exactly we are here. We need to have a reality check in how many of our patients can afford lorlatinib and alectinib. You need to have a crizotinib and stuff like that. Also, what we need to understand is not everybody will get a second line therapy. Only 1/3 of the patients will actually not get therapy. 2/3 of people will actually get therapy. So that is very, very important. Now, Nandini presented a very complex kind of thing. I'm just going to tell you simple things. Resistance to ALK TKIs, second generation, first generation, third generation. If it is the first generation or second generation, you will have an on-target mechanism or you have an off-target mechanism. If you use third generation to start with, you will only have an off-target mechanism. You will not have an on-target mechanism. That is important. So this is what exactly says. So on-target basically means you have it absolutely on the ALK range. You can have ALK amplification, ALK duplication, ALK mutations. Off-target basically means you will have, KRAS, EGFR, all those things which make us feel good over there. If people have still not understood, there's a very easy way to understand this, that this is an on-target mutation and this is an off-target mutation. So, I think everybody understands what I'm talking about. I don't want to give into examples over here. So, this is the off-target resistance one which comes if you have KRAS or a MET or something which comes up. It is an off-target one. In the ALK-dependent resistance mechanism, you have hell lot, you have a number 115. You can have your card numbers, 74041234 and you can say, yes, there's some mutation over there. But the most important of them which occurs after the second generation is G1202, which is not sensitive to anything except for lorlatinib. So the tip number 1 is, if you want to do a resistance mechanism, please do not do a hotspot panel NGS because this will not show you much of the things. The ALK mutations which will come anyway are going to be sensitive to all the mutations. You want to look at everything. So once you have a patient who has progressed on this, please go ahead and do a broad panel NGS. Second tip, not all progressions are created equal. You can have oligo progression, you can have true progression. If you have an oligo progression, please do not treat. Involve your radiation oncologists, involve your surgeons, involve your RF people, involve them. Not all of them can be treated equally. And this is a study which basically said that if you add a localized therapy to somebody who progresses, your PFS can increase by 4 to 5 months also. So tip number 3, not all progressions need a change of treatment. Yes, you tell your patient, we'll give you some RT and then kill them off. Now this is, let us say you have given second generation or third generation, second generation TKIs, and then there were a lot of cohorts, and this is a lorlatinib study basically, and we were looking at the 3B, 4 and 5 cohorts over here. What it basically found out was that if you give lorlatinib after second generation or a first and second generation, your response rates are only 43% and the PFS is only 5.5 months. So, and again, this is also if somebody gives after ceritinib, it was 7.3 months. After alectinib, it was 5.5 months. So for all the proponents of Roche or Pfizer, this thing, please understand that lorlatinib in the second line is not the same as lorlatinib in the first line. Your lorlatinib, like we always say, the surgeons say, you go ahead and do a botched up surgery, radiation will cover for that. No, it is not going to cover for that. Lorlatinib in second line is not going to cover for your ceritinib or alectinib which is not working. Now remember, I told you about on target, off target. So if you have an on target mutation, lorlatinib will work better. If you have an off-target mutation after the second, third generation, lorlatinib will not work well. It will work, but it will not work well. Does it make a difference what mutation do you have? 1165, 1196? No, it doesn't make a difference. Some lorlatinib will respond to everything. Some may respond 70%, some may respond 50%, but it is by and large going to respond to everyone. Now, what happens if you give second generation and then you give lorlatinib? So then what happens? Unfortunately, what happens is that if you give second generation first and then third generation, your risk of compound mutations increase. That basically means if you listen to Nandini's lecture and my lecture, your thing of confusion increases. That is compound, and not even a coffee can get you out of that. So you listen to either second or third. If you give both second and third together, you will be confused. That is what is compound mutation. So the tip number 5 is higher risk of compound mutation after second or third generation TKIs. Once you have a compound mutation, please don't bother and break your head. Only this 1171N mutation is one thing which will respond to crizotinib plus lorlatinib. Otherwise, if you have to really bet on that, tell them it is not going to respond to anything. Very, very important. Remember what I told you, 5.5 and 7.3 months with lorlatinib in the second line. Your good old chemotherapy also works very, very well. So please do not forget the old chemotherapy. Never underestimate the power of a common man. Never underestimate the power of pemetrexate based chemotherapy in a patient of ALK-rearranged non-small cell progressing upon to second generation TKI. So that was about second generation TKI if you give first. Now what happens if you give lorlatinib, the crown trial regimen in the first one? Please look at this. No new single ALK mutation, no new ALK compound mutation. So I'll spend 20 seconds extra on this. A lot of people come and tell us, in the thing that why don't you start with 50 mg of lorlatinib or 25 mg of lorlatinib in the first line and increase the dose. My worry is this. When you give 100 mg at 5 years, people who progress, small number, do not have an ALK resistance mutation. But if you give them maybe a 25 mg or 50 mg, you don't know. Maybe you will have more incidence of these mutations. This is just one. So the bypass mechanisms are more important, and tip number 7 is you will not find a ALK mutation. You will basically find a bypass signaling pathway over here. This is the most interesting part of this. Please, in the crown trial was basically held in US, it was held in Japan, it was held over there. Look at the number of the subsequent therapies which were given. Out of 33, 21 people got alectinib, crizotinib, ceritinib, brigatinib. Typically we will say it doesn't really work, and see what happened. 64% of the patient received a subsequent ALK TKI, and the median duration of response was 9.6 months in a clinical trial. So I don't know why that happens, but I have a feeling that, I also don't typically give, but sometimes I have seen that after lorlatinib, you can actually go ahead back and give some crizotinib, alectinib, they might work. Small number data, we don't really know. WhatsApp Gyan, a lot of time people will say MD, M2 amplification positive, this publication in ALK-rearranged non-small cell lung cancer. This is one take-home message from this. Look at this. If you give immunotherapy in ALK positive non-small cell lung cancer, you will get exactly what I got in my first class in molecular, 0. Nothing. Zilch. IM Power Atlas, people will quote these trials to you, but please look at the number of patients, 7, 6, 13, 14. Immunotherapy does not work in non-small cell NSCLC. So tip number 8 in immunotherapy in ALK positive non-small cell lung cancer is no thanks, nada, zilch. So the Indian data, I think Bevas was here in the morning. This was a real world study, a Roseline chart, and my apologies to Bevas. He called me up thrice to give patients. I did not. I was too busy. But what they have basically found out was that the median OS was 93.1 months versus not reached. 93.1 months is 8.5 years. And this sequential lorlatinib. This is Akhil's data from this is the TMH data. Again, they have given a median PFS of 16 and OS of 22 months. But again, there's a small caveat which they have not told. If you give lorlatinib after crizotinib, median was not reached. If you give after 2 ALK TKIs, the median was 7 to 8 months. So that is also something which is there. So just to conclude, not all progressive disease requires change of treatment. It is only modestly active in second line after treatment with second generation TKIs. Sequential use leads to compound mutations. Very few ALK mutations are seen with first line lorlatinib. Immunotherapy, MSG and BMS Please don't come even inside over there. And there's a very promising data of sequential ALK TKIs over here. So definitely there is an importance of plan B, and you are as strong or you are as weak as the weakest link in the town. With this, thank you. And if there are any questions, Sevanti is here in town, you can ask her. Thank you.